Welcome to the video lecture about the high-risk newborn. This is part 5 and will address necrotizing enterocolitis. And we abbreviate it NEC, N-E-C. So necrotizing enterocolitis, when you just look at the word, you can see that the gut has necrosed. It sloughs and it can actually perforate. When it perforates, it can lead to peritonitis, and as a result, the baby may end up losing a part of its bowel, leading to the short gut syndrome that we discussed with the GI content. We don't know the exact mechanism of NEC, but when you recall that during a time of low oxygen in the body, all the blood is shunted to the vital organs, so the heart, the kidneys, and the brain, then to the liver. But do you hear the GI tract in there other than liver? No, you don't. So as a result, there may be less flow to the intestine itself, and as a result, there is necrosis. And here's some pictures of that necrotic gut. And that's actually quite a bit of intestine that's been removed. And you can see the top picture that there's nice, healthy gut, and then there's a section of necrosed gut. And these are even worse, where the bowel was perforated. So what's this going to look like on your baby? They may end up having increase in their gastric residuals, which is why it's important that you aspirate prior to feedings. Then they can have abdominal distension. And so instead of them having that nice soft gut, the belly gets bigger and bigger, and it can get to be so big that it's tight and very shiny. We will see bowel loops on the x-ray, and that's pathognomonic for necrotizing enterocolitis. At the same time, when you auscultate the abdomen, there's going to be a decrease in their bowel sounds. Any stools that are passed, you need to test for occult blood, and in this instance, they're going to be positive. With the decreased mobility in peristalsis, then the baby's going to have an emesis, and it's not going to be formula, it's going to be bile stained because there's nothing propelling forward in the intestines. So the classic sign on x-ray is what they call the pneumatosis intestinalis, which is just air in the gut. If necrosis has happened, and especially if there's been perforation, watch for signs of sepsis in this baby. If the baby becomes shocky or develops cellulitis, the prognosis is poor. And so this baby is pre-op. You can see that it's not very old. The umbilical cord is still attached, but there is some distension that's encircling that umbilicus. And then the picture on the other side is after surgery. And here's some more pictures. You can really see a lot of air in that one on the bottom right. That whole gut is full of air, and you can see the distension where this belly is just bulging out to the side. So what do we do for this? Try and find it early. So we have to really watch these babies. We have to monitor how well they're tolerating their feedings, and when we increase the volume, we have to do it slowly. Monitor their I&O. We're going to measure their abdominal girth, and this is right just above the umbilicus all the way around. Assess their gastric residuals. Is this baby vomiting? And if they do vomit, we're going to go ahead and do an occult blood on the emesis as well as that stool. If necrotizing enterocolitis is suspected, or the doctor says, yep, absolutely, this is what they have, immediately the baby is put NPO. You're going to put an NG tube down so that we can decompress part of that belly. If the baby does not have an IV, we're going to start one immediately and provide hydration. Usually we're fine to give them at maintenance level. If they're suspecting that there's perforation, then we're going to administer antibiotics and then prep this kid to go to the OR for a bowel resection. They may end up with a temporary colostomy. If there's not that much that's necrosed, they can do an end-to-end anastomosis and then continue to monitor your baby for signs and symptoms of sepsis. And this ends the lecture on necrotizing enterocolitis.